Okay, welcome everybody to our very first vitamin D study hour presented by GrassrootsHealth. And I am incredibly honored and grateful to have Dr. Renu Mahtani join us today. And I do want to say it is, what is it, midnight right now for her. And so she is taking that, she's given up some of her sleep tonight to be here with us. But Dr. Mahtani is a practitioner of the Coimbra Protocol. She is an expert in autoimmune health, nutritional medicine, and vitamin D therapy. And she has a background in both internal medicine and metabolic and nutritional medicine. She is an author, educator, and an international trainer of other physicians in the Coimbra Protocol. And today she's going to be reviewing a recent paper that she published titled Prolonged High-Dose Daily Oral Vitamin D in the Management of Psoriasis, a Retrospective Chart Analysis. And I put the link to that paper in your registration confirmation emails. It's also posted to our website. If you need me to repost the link, please ask a question in the question box and I can post it there. Just a few reminders. Please submit your questions for the speaker to the Q&A box. Questions will be answered after Dr. Mahtani finishes her review. Questions that were submitted prior to the webinar and those that are most related to the topic will be addressed first. And we cannot answer personal medical questions during the webinar. Yes, the recording will be posted to our website. And I do want to make a very important notice. We're talking about therapeutic doses of vitamin D, and it's different from physiological doses of vitamin D. So for individuals who are listening to this and wanting to try vitamin D therapy for themselves, please seek the advice of a qualified practitioner. And before I hand it off to Dr. Mahtani, I want to remind everybody that we have these study hours going every Wednesday, most Wednesdays, sorry. Our next one is with Dr. Bruce Hollis on prenatal vitamin D and neurocognitive outcomes in children. And following Wednesday will be with Dr. William Grant on vitamin D studies, guidelines, and recommendations, and why there's so much confusion and disconnect there. Additional questions, and if you have stories to share of your experience with vitamin D, please feel free to email them, jen@grassrootshealth.org. They'll come to me. We are a 501c3 nonprofit, so your donations are always welcome and appreciated. And I want to say thank you to those who support us. And with that, let me go ahead and turn it over to Dr. Mahtani.
Hi, Jen. Am I audible?
Yes, I can hear you.
Thank you. Thank you so much for this wonderful opportunity. And it's an honor to get this platform and be able to share something which is of so much use. And I'm sure it'll be useful for all the audience out here. So should I start my presentation?
Yes, please.
Thank you. Just give me a second, my dear participants. Let me just share my screen. Yeah. So greetings from India for everyone around the globe here. I'm sharing with you some, like Jen rightly said, it's about how to use vitamin D as a therapeutic agent, let's call it, for managing various autoimmune conditions. And today it's about dealing with psoriasis. So I've been into this field for a long while because I myself am a psoriatic, or let me say I was a psoriatic, having gone through it. And that's what got me close to my teacher, my guru, as we call in India, Dr. Cicero Coimbra, whom I owe all my knowledge and all my confidence in this field. So I went to learn this technology, this science from him in Brazil. And yes, he did tell me, Renu, there's no looking back. You'll have so many people suffering and coming to you. And yes, I do agree what, sir, you said to me. So Dr. Coimbra, a neurologist, he was using vitamin D for dealing with patients of multiple sclerosis. And he noticed that their other autoimmune conditions were also coming in control with the doses of vitamin D that were being used basically to manage multiple sclerosis. I would try to make my talk short and crisp. So, friends, few slides on mechanisms as well, because here we are talking about the therapeutic potentials of vitamin D. We all know that vitamin D is a global pandemic, its deficiency is a global pandemic, and it definitely needs to be corrected with physiological doses. Okay, but I'm going to touch upon the therapeutic potentials. Why? Because vitamin D is something beyond what we ever thought. We were initially in the thought process that it's only needed for healthy bones, but now science has proven that vitamin D works on every cell of the body because there are vitamin D receptors present in the nucleus of every cell of the body, including our immune cells. So this slide shows how vitamin D works on various immune cells. And at this juncture, I would just like to highlight there are four gross categories of cells which carry on various functions. And the Th17 cell mechanisms are one predominantly responsible for a variety of autoimmune disorders. Okay, T regulatory cells, it definitely needs a mention because the recent Nobel Prize has been given to the identification of the importance of T regulatory cells. They are needed to create a balance in the immune response. We want it neither less nor more. So, vitamin D is a very intelligent molecule, you know. It is not going to suppress the entire immune system. It's found to be an immunomodulator. So, it helps to suppress the Th17 mechanisms which lead to autoimmune disorders, but enhance the T regulatory mechanisms, which are needed for good immune functions. At the same time, there is an interplay between the Th1, Th2 pathways, and vitamin D works there to the advantage and strike the right balance between the two. So it becomes a regulator rather than a suppressor of the immune system by managing this Th1, Th2 balance, suppressing the Th17 reaction, friends, and also helping the differentiation of the T regulatory cells. So here you can see how it strikes the balance between the Treg and the Th17 cells. And all these functions happen where? Inside our immune cells. Okay, this is just a, what should I say, a diagram to show many things happening inside, but I'll make it crisp and concise that vitamin D, which we ingest or we get from the sunlight, it actually goes through a couple of processing mechanisms in the body, in the liver, and from here that form of vitamin D comes inside the cells, including our immune cells, where it is converted into the active form inside the immune cell with the help of certain enzyme expressed by certain genes. Right? There are certain genes in the body which help to express certain enzymes to make this possible. And then this active form of vitamin D goes to the nucleus, the hub of the cell, where there is the VDR or the vitamin D receptors are present. And then here it influences the mechanisms, you know, to get all the Treg cells, Th17 and all the other pathways happening. Yeah, you can see here how it also leads to production of natural antibacterials, antivirals called cathelicidins and defenses. So it has multitude of functions, right? The point to highlight here is all this is happening inside the immune cells, and we will need this little information very soon to understand how this keeps us safe from problems. Because the first thing that we think about vitamin D is about, is it toxic? Will it lead to toxicity? But because these mechanisms are happening inside the cell, production happening inside the cell, toxicity becomes a super remote possibility despite high levels of vitamin D being present in the blood around it. Okay, so we'll come to that very soon. Well, friends, the receptor which you saw, the vitamin D receptor inside the nucleus of every cell, well, these receptors, you know, you can say they get some genetic alterations occurring in them called as polymorphisms. And there are different types of polymorphisms with different type of autoimmune disorders. And well, this just shows that there are some polymorphisms identified in association with psoriasis too, which leads to what? Something called as vitamin D resistance. Now, this point is important to know when we are dealing with the therapeutic part for autoimmune diseases. It's a lovely paper which discusses that in detail, that vitamin D resistance is found to be a possible cause of variety of autoimmune disorders. What does it mean? It means that vitamin D levels could be really good in the blood, but the response is not occurring. The biological action of vitamin D is not really happening because of the vitamin D resistance. Yeah. And how to combat it? To combat this resistance, one needs to use higher than the physiological dose of vitamin D. And that's how it comes in the bracket of therapeutic high dose vitamin D protocol, popularly called as the Coimbra Protocol. Means we have to give more vitamin D to beat or to combat this vitamin D resistance. So let's make it simple. What is the cause of autoimmune disease like psoriasis? Either vitamin D deficiency to start with, and if there is no deficiency, levels are good, still there could be vitamin D resistance, which we have to tackle and deal with. So what are the various tenets of Coimbra Protocol? Let's quickly see them. Number one, let's know that vitamin D is a very potent immunoregulatory molecule and plays a very vital role to balance the immune response. See, any autoimmune disorder means my own immune system is attacking me, right? Which it should not be doing it. So we want this hyperactive, dysregulated, misguided immune system to come to a state of balance. The wrong things happening have to be calmed down, and the good things have to be kept intact. And this all comes in the domain of immune regulation, which vitamin D can do so efficiently. Okay, so autoimmunity, point number 2, is found to be associated with resistance, as I just mentioned, to the effects of vitamin D due to genetic polymorphisms. To compensate for the resistance, which we see as less effects of taking vitamin D, one has to use higher levels of vitamin D. And 2, it has to be taken more frequently on a daily basis. So individual requirement of vitamin D varies based on the degree of vitamin D resistance. And now comes the question, how do we measure this resistance? Well, there is no direct indicator or a direct test to say that, wow, if this is there, there is vitamin D resistance. So what is done is that the PTH is measured. PTH is the parathyroid hormone, which has a relationship with vitamin D. Okay, we'll just see it in the next slide. So what we've seen is that what is the effect of vitamin D happening on the PTH? Just wait a few seconds, friends, it'll be clear. So we do the testing of not just vitamin D levels at the start, we do PTH, and we try to keep a check on calcium. We do the levels of ionized calcium. So now this slide, which I've been saying I want to discuss with you, is the relationship between vitamin D and the parathyroid hormone. It's an inverse relationship, like a seesaw, as you can see here. So if the vitamin D levels are low, or the vitamin D effect is not happening because of vitamin D resistance, the PTH levels would be high or will be in the upper range of normalcy. Okay, and when vitamin D is given and the action occurs, because of the vitamin D action, the PTH levels are expected to come down. Okay, this is the inverse relationship between the two. Now, when there is vitamin D resistance in the body, one is giving vitamin D, but the PTH doesn't come down as expected. It comes down or maybe too less, and it's not really low down. So what does it mean? Give more vitamin D and then see that the PTH is coming down. So one has to monitor not just the levels of PTH, but how much is the drop or how much is the lessening of PTH or the PTH suppression that is happening because of vitamin D. And that would be the index of vitamin D utilization. Means the action is happening. Okay? I hope this point is clear. So, as doctors, we have to monitor these mechanisms of the body. One cannot just randomly take vitamin D, just checking the levels and say, oh yeah, it should show results on my psoriasis. Hence, thanks Jen for highlighting this at the start, that it has to be monitored by trained doctors in this methodology. So now if the PTH levels are not dropping by taking vitamin D, it means the body is not making proper use of D due to vitamin D resistance. And the answer is giving more. So PTH inhibition is the most valuable index, and that is how vitamin D resistance is gauged or assessed functionally. If not suppressed, what does it mean? It is safe to increase the dose of vitamin D. The levels could be really high, but one can give more vitamin D if the PTH is not getting suppressed. Okay, so just to highlight this point again, when within the reference range but not yet at the lowest value, vitamin D dose can be increased. Okay, at the lowest value but still within the reference range. Reference range means when we check PTH, for example, a lab could be having a range of 15 to 65 unit picogram per ml. So the range is big, 15 to 65. Okay, and we monitor based on the change happening there. And if it falls down to below the lowest range, it means one has to reduce the dose of vitamin D. So it's the doctor's job to take the call. Well, friends, based on this principle, the vitamin D doses which have been commonly found to be, showing some better results under Coimbra Protocol, you can see how multiple sclerosis and all needs higher doses. And in the category of psoriasis and associated conditions, 300 to 500 international units of vitamin D per kg body weight per day. I repeat, 300 to 500 IUs, international units of vitamin D per kg body weight per day, of course, monitored with the changes in PTH. I'm sure the question that is ringing in our minds, oh my God, this is too much. Toxicity, how do we deal with that? Well, friends, vitamin D now has been shown with various studies to be not really toxic as thought of. And I'll just share this one link. If you're interested, you can go through this paper, a lovely one where 7 years follow-up has been done to patients taking how much? 5,000 to 50,000 international units per day long-term. And the levels have crossed 200 in few of them, but no clinical toxicity seen. Okay, and I must share that here, I'm going to take my pointer here to show you that in the past, in early 30s and 40s, that time there are papers that high doses of D were used to treat autoimmune conditions. Rheumatoid arthritis, asthma, tuberculosis, and what doses were used? Can you see that? 60,000 IUs to 3 lakh IUs per day, right? See here. How much? 1,50,000 to 6 lakh international units a day for rheumatoid arthritis. So it has been taken in the past, and now more scientific studies are happening, researches are happening, we can prove things. And this is a lovely paper which says that there is enough evidence that vitamin D toxicity is one of the rarest medical conditions. And it typically happens when high doses are taken not just for a long time, but underlined, without monitoring for hypercalcemia. Hypercalcemia means high calcium levels in the blood, right? So what does it mean? That if one can prevent hypercalcemia from happening, high doses of vitamin D can be taken safely. So it's high calcium that could be toxic, but not really high levels of vitamin D in the blood. And same has been, sort of documented with this another great paper, safety data in patients with autoimmune diseases during treatment with high doses of vitamin D, according to the Coimbra Protocol. Yeah, 319 patients over 3.5 years using this dose, and safety document. Thanks, Jen. Thanks, Grassroots Health, for some of the lovely slides you have. This is one of them, where various studies on vitamin D intake and toxicity have been concised into one summary. The gist is toxicity just not seen below 30,000 IUs per day. Yeah, even people are scared of taking these doses. Or, in other words, if you want to see through blood levels, no toxicity below blood level 200 nanogram per ml for sure. And of course, calcium becomes a big factor. No wonder, apart from PTH, we monitor the ionized calcium or the corrected calcium, which is the free bioavailable form of calcium that should remain within normal limits. It should not be going above the upper limit so that the patient doesn't land up into hypercalcemia from any form. Okay, and hypercalcemia is ensured by seeing that they are not, overtaking or overdoing with calcium, which is a common tendency. Yeah. So if they are taking calcium supplements, they could be stopped temporarily, blood tests monitored, dietary limitations, dietary restrictions of calcium rich food, and monitored with periodic ionized calcium checking as well. Okay, friends. And of course, vitamin D therapy is a teamwork. There are some other vital minerals needed which do the job of a cofactor. And the most important is magnesium. Good quality salts of magnesium are vital in this protocol because magnesium is a cofactor involved in various steps in vitamin D metabolism and conversions in the body. Plus, it prevents hypercalcemia from occurring. Plus, it has many miraculous functions which are beyond the scope of today's discussion, and it's vital to give that. Selenium, important for skin, important for the hair and thyroid balancing in the body. It's an antioxidant too. Zinc, a very, very powerful mineral needed also to enhance the functioning of vitamin D, to help reduce the vitamin D resistance, B12 correction, and of course, my dear friends, omega-3 fatty acids needed important. So now, at this juncture, I'm sure we can see that vitamin D is saying, my dear friends, trust me, I'm not bad at all. I'm good. I'm your friend. Yeah, I'm the chemical representative of solar energy, isn't it? Nothing runs without the sun. So now let's see how this vitamin D has been used, or let us say documented. The first paper published on the use of vitamin D in psoriasis and vitiligo was by none other than Dr. Coimbra and his team. It was a pilot study on 25 patients, and they have used 35,000 international units of vitamin D daily for 6 months and seen positive outcomes. And which gives momentum for more publications. And I published a case series of patients, case study 2022, where I used up to 60,000 international units per day in few patients and documented results. And then this latest publication of mine, which Jen was mentioning, and thanks to her for realizing the potential. This has just come in. It's a long-term review on 95 patients treated with high-dose vitamin D, which I'm going to highlight in front of you right now. It's a retrospective analysis of 95 patients. Doses used were 30,000 to 60,000 international units over a period of 6 to 12 months, and then followed by lower daily maintenance dose. It doesn't mean that vitamin D was given for 6 months and stopped. No, not at all. It's food. It is cellular nutrition, which helps to correct the abnormal or deranged cellular mechanisms. The dose was eventually reduced to a maintenance dose. So what does this paper do? Number one, I give the detailed analysis done for 6 cases which represent how the doses were individualized for each patient, because it is not a one size fit for all protocol. Yeah. The doses differ depending upon individual vitamin D resistance the patient has, the duration of the problem, right? And other conditions associated with that. And of course, the dose of vitamin D was adjusted based on periodic checking of parathyroid hormone, ionized calcium levels, and the The psoriasis progress was monitored using the standard PASI scoring, or the psoriasis area and severity index scoring. So I will first quickly share these 6 cases and then the statistical analysis on all the 95 of them, and then the house will be open for your questions. So one of the cases was this 43 years old gentleman. Can't go too much into details. His starting vitamin D levels were very low, right? So we had to first take care of the deficiency by giving physiological doses, let's call it like that. So we gave a loading dose. All the details are there in the paper. And then once, the levels come up, we gave the daily 30,000 international units of vitamin D. The criteria followed was based on body weight, right? So if somebody was in the body weight range of 75 kilograms or less, we started with 30,000 international units of vitamin D dose per day. And if it was 75 kgs or above, we gave them starting dose 40,000 international units of vitamin D per day. And we were monitoring the parameters every 2 months on an average. Some patients needed earlier, like for example, if their calcium levels were near the upper limit, we would check it after 1 month. And overall average 2 months, and the doses were edited based on what is the change in PTH, and two, very important was the clinical response. Is the patient showing response or not? So, well, this gentleman, he showed a complete control of disease by the end of 4th month. The PASI score came down to 0.6, and then he was put on a maintenance dose of 20,000 IUs, and now he is taking how much? 60,000 IUs, not daily, per week, right? In India, we get 60,000 preparations, which he takes once a week. So the average is about 8,500 units per day, which is physiological, and he's in remission for more than 5 years. Young boy, 26 years old. His vitamin D levels were also very low, and his almost the whole arms, legs, everywhere, the back had big patches, right? The thighs, the legs. Again, he was given a loading dose. We used to give 6 lakh international units over 10 days and then put on 30,000 daily. PTH levels were monitored. So you can see when he started, his PTH was 54. Okay. Checkup periodically came down to 48. Not a good drop, despite taking 30,000 for 4 months. His levels were above 100. By the way, friends, all the patients who were in the study, their vitamin D levels crossed 100 nanogram per ml for sure. We had patients with more than 150, and the labs here were measuring more than 150. We didn't really know what is the exact value above that. So by 3 months and max by 6 months, they were all above the level which scares people. But the PTH levels were never coming down to below the lowest possible range. Like in this boy, from 54 to 48, lower limit was 12 for this lab, and 50% clinical improvement. So we decided to continue the same dose. We could have increased it also, but well, this decision was made. Maybe his body weight was not too much, keeping that in mind. And by the end, you can see how his PASI score improved. PTH came down to 37. It never touched 15 or 12. But because there was significant improvement, we did not unnecessarily increase the dose. So it's not that we have to bring the PTH down to a particular level to say, oh, the vitamin D is working. It's just a guide. It's a parameter to show whether I can increase or I need to keep the dose same or reduce it. Calcium levels were maintained, and he's doing pretty good on 15,000 IUs per day maintained. Sorry. A young boy with palmoplantar, you can see how they were scaling in the palmoplantar region. And when he came, his levels were already 94. Vitamin D levels, he was taking 20,000 international units of vitamin D daily. But you see how his PTH was not suppressed completely. It was 37.5 at the start. So vitamin D dose was increased, and with periodic follow-up, max dose given was 40,000 IUs per day. He achieved good remission, and now he needs a maintenance dose of 25,000 IUs per day. Because if he reduces to less than this, his skin becomes irritable, it becomes itchy, And on this dose, he is not only on remission, all his parameters are good. There is no hypercalcemia, there is no kidney derangement. A lady with lupus and hypothyroidism came with this itchy erythematous psoriatic involvement, and her vitamin D levels were so and so. We gave her all these doses. She has done pretty good, and all is maintained well. And well, good enough. She needs again that same 60,000 per week, and she's in complete remission about the psoriasis. Now, this gentleman, his area of involvement is not much. You can see just the elbows and the knees, but he needed higher doses than what you can think of. We had to start with 40,000 because his BMI or his body weight was more than 75, really more. And starting levels were, you can see, 15. Anyway, started with 40,000. Not much change occurring. PTH came down from 83 to 57. We increased the dose. We had to go up to 50,000. Sorry, there's an error here. 50,000. And now he's on a maintenance dose of 30,000 per day for more than 5 years. So we had to really take it up for him. Although the level of the area of involvement was not much, but his vitamin D resistance was higher, as you can see. This young lady, the sixth case, not only having psoriasis, but that, overlap with vitiligo. The patches were lighter than the surrounding skin, inflamed. And even I was apprehensive because vitiligo is tougher to deal with in my clinical experience than psoriasis. But she did so well, as you can see her pictures now. And she also needed very high dose. Yeah. Starting levels of vitamin D 22, PTH 44, PASI score was 26, started with 30, not much response, had to go 45, and we had to take her up to 60,000 international units per day because the PTH was within the range. Skin was not improving, and she took some time, but she did show improvement, as you can see. PASI score came down to 4.2 from 26.8, and eventually the dose was reduced. And now this young lady is on a maintenance dose of 30,000 a day and doing pretty good. Interesting, isn't it? So what can we say as a summary to these 6 cases? The requirement of dose was variable. The maintenance dose also which the patient reached was variable, ranging from 8,500 per day to even 30,000 per day. But you can see that all these cases got a good PASI 90% improvement, no hypercalcemia, no toxicity, no kidney derangement, followed up over 3 to 5 years. And we can say that, yes, it's a therapy worth try. And friends, at this juncture, I can say the earlier it is given, less is the need of other medications and better results. The earlier it is started. And then finally, the statistical analysis for all the 95 cases. General, PASI score declined over 12 months. This is general for all, from 17.83 to 6.52. More than 76% achieved 50% improvement in the PASI score, which is considered clinically significant. More than 57% got 75% improvement, and around 20% got 90% or more, let's call it complete remission. All had vitamin D levels more than 100, more than 150. Sorry for this, it's nanogram per ml, within 3 to 6 months of starting. Okay? And we were monitoring with the PTH changes. No adverse effects generally noted. Few of them did show high calcium, hypercalcemia occurring midway, which was corrected with dietary corrections and use of vitamin K27, and we did not see renal derangements. PTH levels declined progressively, and it's interesting. And by the end of 1 year, we saw that the PTH levels had almost stabilized, and they were not going down below that, which will be evident with this plot here. Starting PTH levels coming down, and then they stabilized, they plateaued. And this is what is observed in other studies as well. This, what you call it, that seesaw relationship between vitamin D and PTH levels was also observed in the study, that as the vitamin D levels go up, the average PTH levels were coming down. Okay. So friends, finally, I can say that with the study, I we did show on Dr. Coimbra's pilot study, and so many other patients have also reflected upon that vitamin D is a powerful immune regulator. It's an immune modulator. Genetic polymorphisms, of the vitamin D receptors have to be dealt with, more doses of vitamin D to combat the vitamin D resistance and achieve meaningful clinical outcomes. And this is done by monitoring the parathyroid hormone levels, which is the best biological indicator. The change in parathyroid hormone level is the biological indicator to estimate the optimal dose. And there are other studies too which suggest that vitamin D level toxicity doesn't really happen up to 250 nanogram per ml, provided we don't allow hypercalcemia to occur with a calcium restricted diet and magnesium and the use of K27. So looking back, not just autoimmune disorders, even in general, vitamin D is becoming very important. It's like a must. It's no longer an option in 2025 and beyond. It's a non-negotiable necessity for the cells because it's like a very vital defense and support to our health system. And fearing vitamin D toxicity and not taking vitamin D, such beautifully said by Dr. John Cannell, that worrying about vitamin D toxicity is like worrying about drowning when you're actually dying of thirst. It's so beautifully said. So one has to quench the thirst rather than worry about drowning. So friends, we doctors take the Hippocrates oath that it's the love for humanity that makes medicine move on, and that is real science. And with that, I would say thank you to the organizers for giving me, Jen, this opportunity to share my paper, and I'll be very happy to answer your questions. Let me stop the.
Thank you so much, Dr. Mahtani. That was a really great review, and you went beyond and going into the mechanisms. I'm sure a lot of people will deeply appreciate it. Um, so I see a lot of questions have come in to the Q&A, and I have a few others that were submitted ahead of time. And I do want to just remind everybody that please email me, Jen, Jen, at grassrootshealth.org if we don't get to your question. If you have any feedback, I disabled the chat. Hopefully nobody, minded too much. But if you prefer chat on the next one, any feedback on how we can improve, please send it to me via email. I would like to start with a question from Dr. Patrick McCullough, whose paper you did share. And he asked, why do you monitor ionized calcium and not serum calcium?
Thank you for the paper, doctor. It gives so much confidence to so many patients. Huh? Okay. Ionized calcium is the unbound form of calcium. Otherwise, calcium could be bound to albumin and other proteins and not be really available. So we want to see the bioactive form, hence the ionized calcium. It's more specific to monitor for hypercalcemia because we do see reports where the total calcium is, let us say, high, but the ionized calcium is within the range, or vice versa. So the functionality is more portrayed with the ionized or corrected calcium because the correction is done for protein binding.
Thank you. This question was submitted during the webinar today and a similar one before. So I'm going to go ahead with this one. What are the specific polymorphism details and what percentages of these polymorphisms are found in the world populations?
Oh, that's a very, very wide question. And it's beyond the scope of this talk. But there are so many types of genetic polymorphisms. And honestly, I will not be able to give you the percentage right now because there are different genetic polymorphisms for different autoimmune disorders, even cancers, different type of cancers. But one thing which is important to, what should I say, highlight at this stage is that vitamin D is a very powerful genetic modulator. Finally, we want to see the effect of the whole thing, whatever the polymorphism may be, right? So vitamin D being a genetic modulator, it modulates, found to be modulating more than 2,000 genes in the body. So it tries to strike the right balance, Let us say the good genes are turned on and the bad genes can be turned off by vitamin D. Hence, vitamin D becomes a very powerful epigenetic factor, and as a genetic modulator, it can bring these genetic polymorphisms into a better state of balance. So I'm sorry, I don't know the percentages right now, but for me, it is more important to know that, oh, vitamin D can help balance it out.
Have you looked at specific SNPs or polymorphisms for the individuals that you've been treating or those in your study, and then compared those SNPs to the amount of vitamin D resistance?
No, honestly, we have not done that because number one, the testing is expensive, and we would rather treat the patients. And honestly, we are now getting into a study of that type. We are getting institutional collaboration to make it happen. And I'm a clinician, and what I could do at my clinical level that I have done, which and doing these genetic studies was beyond the scope from my clinic. And but yes, we are getting into that now very soon, and I hope we are able to show results. And there are genetic studies which are done for various SNPs in the vitamin D metabolic pathways. There are, yeah, but we have not done it.
Are there any other signs, symptoms, or indications of vitamin D resistance or high PTH levels?
Clinically, no. Having an autoimmune disease, I think itself is a sign that there are uh, vitamin D resistance and polymorphisms in the body. But clinically, it's very difficult to say. But yes, I have seen that more the number of organs involved in autoimmune process, more is the vitamin D resistance. Means, say for example, in psoriasis, okay, if somebody has skin involvement, has joint involvement like psoriatic arthritis, right, has nail involvement, means the vitamin D resistance is more rather than only the skin. This is one thing I've observed. Then I've also observed that people who have, say, for example, Hashimoto's in the past, means they have had autoimmunity to the thyroid gland sometime in the past. And now they are coming to me with psoriasis. There, the vitamin D resistance is more, and they need more doses of vitamin D. Then people probably who have been taking a lot of immunosuppressants in the past, long-standing, immunosuppressants, that also influences the vitamin D resistance. But yeah, multiple organ and multiple sites of autoimmune involvement, the resistance is higher clinically.
All right, another question submitted. When the slide says 60,000 IUs over a period of 6 months, is that a total dose or a daily dose? I believe that's a
Daily
daily dose,
dose,
correct?
daily dose,
Okay.
daily dose, monitored.
Yes, yes. Um, in your opinion, can this protocol be extrapolated for people with lupus, RA, and other autoimmune diseases?
Yes, of course. We've been using it. In fact, we have data of many patients of various connective tissue disorders, not just lupus, rheumatoid, scleroderma, Sjogren's, fibromyalgia, yeah, multiple sclerosis. Yes, of course. But once again, the earlier it is used, the better it is. And
Mhm.
since you mentioned lupus, uh, once the nephritis part or the kidney involvement sets in, then we have to be very particular about like what should I say, the dosing of vitamin D, because the kidneys are not excreting or removing the vitamin D the way expected to. So we have to probably reduce the doses. So monitoring becomes important, and we cannot use very high doses of vitamin D once the nephritis sets in.
Okay. And
Yeah.
correct me if I'm wrong, but this is the Coimbra Protocol, and this has been used for many different autoimmune diseases, not just psoriasis, but also multiple sclerosis and that, yeah. And okay, yeah. So we Grassroots Health had the honor of interviewing Dr. Coimbra not long ago. So for anybody interested in learning more about the protocol, you can go to our website or go to our YouTube and find that video. And then we're going to be talking about it a lot more in the coming um, in the future. Okay, so I do have two similar questions here. Um, let's see here. Why would the dose of vitamin D needed decrease over treatment time versus remaining steady after a certain level was reached? And then a similar question, how do you decide on what that maintenance dose is?
Yeah, that's a nice one. So initially, we have to give high dose of vitamin D to break the vitamin D resistance. Let's put it like that. And once the patient is showing clinical response, which is sustained over 2 to 3 months on the high dose, then start slowly reducing the dose at the rate of maybe 10,000 IUs per day, at the rate every 2 months. That's what I follow. And it is absolutely arbitrary. There is, I think we definitely need more studies to work on this thing. And if the patient can maintain the clinical improvement with lower doses, then why should we give high doses? Because the vitamin D resistance part probably gets tackled in the initial, you can say, 5 to 6 months, in some people, even 1 year. And then we can slowly bring it down. And the clinical thing that it is leading to, if the patient feels the symptoms are coming back again, then we take the dose up again. So there are many things which are clinical. I mean, we cannot always have indicators, or let us say markers, at least at this juncture right now. Maybe something comes up later with time. Yeah,
So it's almost like in the beginning, you have a big fire to
yeah,
put out and you have to use a lot of
absolutely.
water. And once you've got that fire under control,
Exactly.
you don't need as much. Okay,
Very well
thank
said.
you.
Yeah, very well said.
Um, are we able to get a copy of your PowerPoint presentation?
Sure, sure.
Okay. And then I have a compliment from Mary. Your research design is elegant, understandable, and so exciting. Thank you for sharing with
Thank
us.
you so much, Mary. Thank you for that.
I I have we have maybe 5 minutes left, so I'm sorry if I don't get to your question, but I'm going to go through. Um, a lot of people ask about vitamin K2. So what
Yeah.
about?
Yes, sure. So vitamin K2 is a very interesting molecule. Yeah. K27, let's put it like that. And you could call it like it monitors the traffic of calcium. So what happens is, when we are taking high doses of vitamin D to beat the vitamin D resistance, the other functions of vitamin D are also happening parallelly, right? And one of them is absorbing calcium from the gut, right? So that's what leads to hypercalcemia. Now, what does this K2 do? Through certain proteins, it diverts the calcium from the blood to the bones and doesn't really allow it to get deposited at wrong places, like the blood vessels, the heart, the kidneys. I mean, we don't want microcalcification there. We want the calcium to go to the bones. And this is done by K27. So when we are using high doses of vitamin D, K2 becomes much more important than just for the physiological doses, right? So the K27 dose ranges from, say, 200 to 400 micrograms a day, which is given along with it. And of course, the calcium is simultaneously monitored.
Yeah. Okay. And so for patients with coronary atheroma, I believe that's calcium deposits in the blood vessels, it's still okay to give them higher doses of vitamin D, but do you have to give K2 with that?
We do give K2. Of course, we give. In fact, K27 has been studied independently beyond high doses of vitamin D as cardioprotective. So, in fact, anybody with ischemic heart disease could do good by taking at least 100 micrograms of K27. And yes, I've seen preparations in the US combining vitamin D and K27 for the heart. So, I've seen products of, I think, 5,000 international units of vitamin D with 100 micrograms of K27 available there. And it's a good thing to be taken for the heart. And when somebody has coronary artery disease history, who knows? I have calcification in my coronaries. I mean, nobody can say that. So we all could be in that bracket. So K27 is a good thing to be added. Yes.
And what about individuals with kidney stones? We had somebody ask specifically
Yeah.
about calcium oxalate type of kidney stones. Can they be taking these higher doses, and can vitamin K2 prevent the oxalate from binding to the calcium so that it doesn't get eliminated from the body properly, or what is your
I
suggestion?
was waiting for this question because it comes up, and it's it's a good question, because people think that nephrocalcinosis happens because of vitamin D. Now, There are so many people who get nephrocalcinosis and their vitamin D levels are low. They've never taken vitamin D in their lives. There are so many of them. How does that happen? So there are errors of calcium clearance in those bodies. Means, calcium in the body also has to be discarded. It can't remain building in the system. So there are mechanisms in the body, and if there are polymorphisms there or errors happening there genetically, that person is more prone to nephrocalcinosis. Like it runs in families. I have a patient who's till now passed 48 times kidney stones, irrespective of the protocol in my practice in the past. So he has a tendency to make kidney stones. Let's put it like that. So let's have that clear in mind that kidney stones can be made irrespective of vitamin D levels really going high. Yeah, in my patients, I do take family history of kidney stones. And, that gives me a red alert that monitor the calcium more stringently in this subject because he or she has a family history of kidney stones. Now coming to the high dose vitamin D and K2. Yes, my dear friend, K27 does prevent calcium oxalate stone formation. It is proven, it is there, it is documented. So K27 becomes very important to be added when there is a family history of nephrocalcinosis, otherwise too, whether taking high dose or whether taking physiological dose to prevent it. We monitor it. We do monitor it. Yeah. And then we also monitor the, calcium creatinine ratio in the urine because many patients could be passing the calcium in the urine, although the blood levels are normal. So we look for all these parameters in these cases, but it doesn't mean that we cannot give them high dose vitamin D. We do monitor it carefully.
Got it.
And then, of course, you have to bring it down to the maintenance dose. Yeah. Sorry.
Just a couple more questions. What if the person with psoriasis is already on corticosteroids? Can the steroids be abruptly stopped and then they start the Coimbra protocol?
So there are so many patients who come who are not only taking corticosteroids, they're taking other immune medications, other biologics as well. Patients come, they come as the last resort also to vitamin D. And of course, that it becomes a longer journey and tougher to deal with. But we don't stop what they're taking at the start itself because they will go through a rebound. That's number one. And we have to allow the internal mechanisms to get corrected first. Yeah, so that's what I tell them very clearly. Whatever you're taking, I respect it all. You needed it at the acute phase. No conflicts. Please continue. Let's build up this system through vitamin D. And once you start feeling better after addition of vitamin D therapy, then I guide them. I slowly, gently taper it off. We never stop steroids anyways suddenly. They have to be tapered off. Otherwise, there would be rebound reactions. So vitamin D first takes over, patient feels better, and then we taper it off. And we've done it for quite a few patients. Yeah.
Are there certain types of individuals or cases of psoriasis that are more likely to respond to vitamin D than others?
Yeah, definitely. I've seen that the erythrodermic psoriasis, where there's more redness, diffuse inflammation of the skin, it responds better than plaque psoriasis. Plaque is, discrete patches present all through in the body. Palmoplantar psoriasis responds very well. We've got great results in palmoplantar psoriasis, which is thought to be difficult to treat. We get very good results with vitamin D therapy. Plaque psoriasis also responds, but it's tougher than these two. Scalp psoriasis takes a longer time. Nails, of course, And if somebody has associated arthritis and all these other involvements, it's a longer journey. But yes, I would say erythrodermic, palmoplantar, and earlier started in any type of psoriasis, the results are better.
And somebody also mentioned lichen planus. I'm sorry if I'm.
Yeah, it's lichen planus. Yeah, yeah.
Is
Yeah,
that
that too is an autoimmune. Oh, yes, great results with that.
okay?
Lichen planus, then it comes as LPP, lichen planus pigmentosa. I myself have gone through that. You saw my picture. My skin was dark. So there, the pigment production is very rapid rather than the epidermis making scales. So it responds. It takes time, but it does happen. Yeah.
Well, my very last question. Are you available for consultations in the United States?
Not physically all the time, but yes, online. I do have many patients from the United States, and we do give online service. So, sure, yeah. And I must say one more thing that many times the skin is inflamed because of underlying inflammation, of course, and let us say mix of infections like fungal infection, for example, bacterial infections. So I do treat them with medications initially for a few days, along with the vitamin D. And I think that is also important. And in fact, I was discussing with Dr. Coimbra too, that even for multiple sclerosis patients, we know that the viral etiology is there at the backdrop, fungal infections are there at the backdrop. So it's good to treat them. So I
Yeah,
do that. Yeah,
I did have somebody ask about mold as well,
yeah,
which can be very difficult to treat.
very difficult. So we have to give them medication for that and get better results
Right.
rather than wait for a longer time. Yeah.
Well, for those of you who submitted or just commented, we have several thank yous in here. And yes, we will be sharing the slides and the recordings. Again, if you have any questions or think of them later on, want to share your own story, have feedback, please email me, jen@grassrootshealth.org. Thank you so much, Dr. Mahtani. I am incredibly grateful, honored, and just I'm gonna have to re-listen to this because I didn't get to focus on everything you were saying, and I want to make sure I didn't miss any of your wisdom that you shared with us today. So, thank you
Thank
again.
you so much. Thank you
And
for the opportunity. And it's actually my pleasure to share this, get this platform to reach out to so many more people. And I must thank you, thank Grassroots Health for making these things happen. It is my pleasure. Thank you. Thank you so much. And if I can be of any other help or association in the future for this, I'll be happy to do so.
definitely. Well, I hope you get a good night's rest.
Thank you. And
All
you have a
right. And
lovely
thanks
day.
to everybody who
Bye bye.
participated today.
Thank you.
All
Bye
right.
bye.
Bye.
See ya. See ya.